Hello, my name is Dr. Habiba Kamarul. I'm going to talk about understanding hemostasis. Hemostasis is a process of blood clot formation at the site of the vessel injury. When a blood vessel wall is disrupted, the hemostatic response must be quick, localized, and carefully regulated. Hemostasis impaired when abnormal bleeding or thrombosis may occur when specific elements of these processes are missing or dysfunctioned. For example, thrombosis is a process when non-physiological blood clotting that not required for hemostatic regulation happens. And this can happen when there is an imbalance of specific elements in these processes. So these are the four phases of hemostatic processes. The first one is endothelial injury and formation of platelet plaque, which is the primary hemostasis. And the second part is the propagation of clotting processes by coagulation cascade, which is secondary hemostasis, followed by termination of clotting by antithrombin control mechanism, and finally removal of clot by fibrinolysis. Let's look briefly into primary hemostasis. Platelet progranulin activity is an important process. When this platelet then exposed to progranulin phospholipid due to injury, and this lead to subsequently assembly of the enzyme complexes in the clotting cascade on the platelet surfaces. So they are the primary players in this process. Then this followed by propagation of clotting process by coagulation cascade. These are the common pictogram that we see to depict these pathways, but they also can be depicted as complex as this or as simple as this. The division of coagulation into two pathways is mainly artificial. It originates from laboratory tests in which clotting times were measured after the clotting was initiated. By the first one, by glass, where it caused a negatively charged surface, which we call intrinsic pathway, and the other one due to addition of thromboplastin, which is a mix of tissue factor and phospholipid, and this we call extrinsic pathway. But in fact, thrombin is already present from the very beginning when the platelets are making the plaque. So it should be depicted more in this cycle rather than a Y-shaped cycles. Let's look at the prothrombin and APTT, PT and APTT, the test that measures the secondary hemostasis. To run a PT test, we require a platelet-poor plasma, which is mixed with tissue factor, which contain phospholipid at room temperature, and then we add excess of calcium chloride to initiate coagulation. In the manual technique, the same time as calcium is added, a stopwatch is started and stopped when we see a clot formed. So the time taken from the addition of the calcium to the formation of the fibrin clot, that's what make prothrombin time. In the automated system, the formation of clot is detected electronically, but the principles are identical. The PT it was first described by Dr. Quick in 1935. The prothrombin time was developed to measure prothrombin factor 2, hence it got the name. But later they found that it also can measure factor 7, factor 10, 5, 2, and fibrinogen. It is to depict extrinsic pathway because it uses tissue factor, which is not found in the blood, but it released when the tissues are injured. The next test, that very common test that we do, is APTT. Again, we use a platelet-poor plasma incubated with phospholipid, and we bring forward to have a contact activator, for example, kaolin or silica. And this has to be followed by calcium. Addition of calcium initiate clotting and times begin. So the APTT is the time taken from the addition of calcium to the formation of fibrin clot. The same thing in automated system. We detect the clot electronically, but the principle are the same. So APTT measures the activity of intrinsic and common pathways of coagulation. For clinical purposes, it can show the function of factor 8, 9, 11, and 12. It is called intrinsic because all the factors that involve are found in the blood, and it requires a contact pathway, a negatively charged surface, to be activated in the lab. So if you ask me which one is the more stronger pathway to form a clot, definitely is PT because it takes shorter time to form a clot. So this is another cartoon to depict the secondary hemostasis. Then once the clot is being formed, so we need a termination of clotting by antithrombin control mechanism. So if this process is unchecked, if the coagulation cascade is keep on going on, it can be potentially explosive and could lead to thrombosis, vascular inflammation, and tissue damage. But this does not happen. Unchecked thrombosis does not happen in our body because we have dilution of procoagulants in flowing blood. That's why it get very dangerous the moment the flowing got blocked by the thrombosis. And also we got removal of activated factors through the reticuloendothelial system by the liver, and also control of activated procoagulants and platelet by our natural antithrombotic pathways. Another thing, most of our antithrombotic pathways are anchored in the vascular endothelium, so the middle they can manage to maintain the fluidity of blood. The last part of this process is actually removal of clot by fibrinolysis. So this is another very elegant and very complex system to remove the clot. So when a patient develops DVT, when we initiate anticoagulant, the anticoagulant is actually to stop the propagation of thrombosis. But the dissolution of the thrombosis has to come from our system, from the fibrinolysis. That's why you see it takes about 2 weeks or 3 weeks sometimes for the clot to dissolve. These are the lists of anticoagulant, antiplatelet, and thrombolytics. But for today's talk, I'm just going to focus on warfarin because warfarin is still very much widely used drug, despite nowadays we have DOACs. So warfarin, as we all know, is a vitamin K antagonist. Their use is challenging because their therapeutic range is very narrowed and they are affected by many factors. So warfarin has a very narrow window of therapeutic range. So when the time spent with the INR above the therapeutic range, it increases the risk of bleeding. But when it's spent the time below the therapeutic range, it increases the risk of thromboembolic complication, which is the first reason why we start warfarin. Okay, let's look at these slides. Coagulation factors are synthesized in the liver and released into bloodstream. Warfarin impairs the carboxylation of coagulation factor in the liver. So the thing is, the functional coagulation factor with GLA residues that make into the circulation are not affected by warfarin treatment. And these are the half-lives of the factors. Okay, the shorter the half-life of the GLA containing factor, the sooner its function is compromised by warfarin. So that's why the depletion of both factor 10 and factor 2 is important in clinical efficacy. And factor 2 has the longest half-life of the vitamin K dependent factors, approximately 3 days. Thus, the desired anticoagulation effect of warfarin does not occur at least 3 days after the drug initiation, despite we already seeing the prolongation of PT time at the earlier time points. So the initial prolongation of PT is due primarily to depletion of factor 7, which has short half-life, about 4 to 6 hours. this slide just to show the position of the factors that being affected by warfarin in the coagulation pathway. So let's look at overwarfarination. So first of all, when we approach overwarfarination, we need to look at the degree of INR elevation. The other one, whether the patient has significant bleeding, and also the underlying thrombotic risk or indication of anticoagulation in the first place. Why the patient received warfarin in the first place. So you can find a lot of material online. So this is one of the guides how to approach INR with or without bleeding. But the thing is, how about in a serious life-threatening bleeding? First and foremost is to stop the warfarin, to tell the patient to stop taking the warfarin. The next one, we can administer vitamin K by slow intravenous. The reversal of warfarin effect may take several hours to fully occur because it depends on new synthesis of coagulation factor in the liver. So the use of excessive dose of vitamin K should be avoided if the patient is not bleeding. The other thing that we can use is prothrombin complex concentration. It has okay. PCC has unactivated PCC, which further divided into 4-factor and 3-factor, and also the activated PCC. Please familiarize yourself with this preparation, which will come handy during emergency. The other thing is the usage of recombinant activated factor 7 generally is not used to treat warfarin associated bleeding because it does not supply the other vitamin K dependent factors that are affected by warfarin. For example, the 2, 9 and 10.